It is my pleasure to introduce Dr. Camile Farah, who is the CEO and Managing Director of Optiscan. He also has an MBA, PhD. He's a fellow of the Royal Australasian College of Dental Surgeons, and then a large alphabet soup after of credentials. And Camile is a commercially driven healthcare executive, a clinician scientist, and global authority in digital diagnostics and precision oncology, with over 25 years of experience leading transformational change across medtech, life sciences, and academic healthcare. He currently serves as a Chief Executive Officer and Managing Director of Optiscan Imaging Limited, and holds multiple non-executive, honorary, and advisory roles within the medtech, life sciences, and healthcare sectors. He's held CEO, board, and C-suite roles in medtech and diagnostic companies, driving commercial strategy, capital raising, global market expansion, and regulatory approvals. Camile is internationally recognized for his deep expertise in digital pathology, optical imaging, and precision medicine, and has been instrumental in translating research innovation into clinical and commercial success and taking disruptive technologies from bench to bedside and from startup to scale up. He's a fellow of multiple professional bodies and a former academic leader and director of major cancer research programs. Camile brings a rare blend of scientific credibility, clinical insight, and commercial acumen. His strategic vision and operational leadership continue to shape the global transformation and future of digital healthcare and integrated diagnostics. And today, he's going to be giving a presentation that's titled Real-Time Digital Pathology for Veterinary Medicine Using Confocal Laser Endomicroscopy. And with that, I'll hand it over to you.
Thank you very much. Can you hear me? Great. So thanks, Caitlin, for the kind invitation. Thank you all for being here, whether I can see you physically or not. I'm told there are many people on Zoom. So just to give you a little bit of background as to what we'll be talking about today and what the nature of the presentation is, I'll talk a little bit about Optiscan, what we do, why we're here, a little bit about the technology, so you get a fair idea of what it is designed to do, both in the veterinary space, but also in the clinical human space, because that's where we operate originally from. And then I'm going to give you a handful of examples of research that's done, has been done with our tech, and it's published, and you'll see we'll cite all of those papers, but then also give you an idea of what the collaboration between Optiscan and the college here is, what we're looking for, and how you can be involved in those collaborations. So happy to answer questions around that. I'm told I've got 45 minutes. I know I've got too many slides, so some I will reserve to just go through very quickly, and some I'm going to labor the points, but the back end of the presentation has got a whole heap of examples of studies and images from a whole myriad of animal models mostly. There are some examples of human models, just to give you an idea of the capability of the technology. I probably won't get through all of that. I'm happy to send the presentation in PDF format later, so you can have that available to you. And by all means, then please come and talk to me. Also, once we leave, and if you've got other questions, please come and talk to Caitlin. Caitlin, hopefully you know Caitlin, because she works here. So come and talk to Caitlin, because Caitlin is the liaison officer between Optiscan and the college, and we meet regularly. We talk about potential projects, and we've got a structure in the agreement between the two parties that we basically agree on what the projects will be moving forward. So it sort of gives you an idea of how we're trying to operate and what we're trying to do. So hopefully that's a little bit of context, and we'll get cracking. So we are an Australian company. We are listed on the Australian Stock Exchange. So there are certain declarations I need to make. That's me. We'll put that up at the end also. If you want to contact me, please feel free to do so. These are the disclosures that we need to put out publicly. So I'm not giving you any, advice on, going and investing or anything like that. This is a strict clinical presentation, but I'm obligated to put it out there. So I will try to shock you a little bit, hopefully not too much, because you're all researchers and clinicians. But this is the thing that I put out there as to why we need this technology, what's our claim to fame, what we're trying to do, and where we see the problems. And we all know, and we believe that this is occurring in human medicine, but I do believe that it's occurring in veterinary medicine. I just came from the VCS meeting in Salt Lake City, and I saw what you guys are doing as far as research and clinical practice. And I think there's a lot of similarities in what we're doing between vet and human. So medicine has moved into the 21st century. There's robotics, there's immunotherapies, there's personalized medicine, genomics, you name it, we're pretty much all doing it in some way or another. However, pathology as a discipline, as a practice, is still stuck in the 19th century. Now, that's a big call to make, okay? Now, I'm very comfortable making that for two reasons. One, I'm a registered pathologist, so if I want to bag pathology, I'm allowed to, okay? And two, I'm the CEO of a digital pathology company. So of course, I'm going to say to you that pathology is still stuck in the 19th century. But think about what we do in pathology, okay? Think about what we actually do every day in pathology. We rely on our clinicians and surgeons to take biopsies and samples and resections. We get our couriers to come and pick them up after we put them in formalin. They go to a lab somewhere close, somewhere far away. We process them. Next day, we have to wait for them to actually sit in formalin. We cut them, we slice them, we dice them. Then we put them through a whole myriad of machines, and then we have to stain them. That's just to do a H&E. And then if we want to do anything a little bit more sophisticated, we want to do IHC or fish or what have you, we start another set of processes. All of that takes time and money. And then you as a clinician, you might get this answer maybe 2 or 3 days later. Most of the time, we're hearing, at least in the vet space, they're getting things back 5 to 10 days later. I know in human health, that's what's happening with us. So the system bears the brunt of all of this. And if you've ever spent time in a pathology lab, you'll understand that a lot of this is manual. Some of it is automated, but a lot of it is manual. And it's very time and resource intensive, okay? Now, however, imagine a different world. Imagine a world where that doesn't occur. Imagine a world where pathology is real time and at point of care. So it's front-end digital, not back-end digital. We all understand there's a whole myriad of players out there scanning slides. We know. I was scanning slides for about 20 years, okay? But that's just adding one additional step to the process. We're talking about digital upfront at point of care. Imagine you going to a doctor and getting a diagnosis on the spot with no delays. Or if you're a surgeon, you're completing your resection the first time completely correctly, because you can see cancer margins and you can see cancer cells in real time. And importantly, if we're talking about pathology, imagine if you're the pathologist having to deal with all of this and you're excluded from the process, because currently the pathologist is sitting in a far-flung place away from where the action is occurring in a clinic or a surgery. But imagine if you can see those cells during the operation. It doesn't matter where you are, we can show them to you during the operation, and you're not getting the sample days later after it's been sliced, diced, and put on a glass slide. That's what our technology allows you to do. And that reel that I'm showing you there on the screen is an actual sample being imaged in real time, and the image is just coming up on our machine in real time. So we don't believe that's the future. We believe this is now, because that's what we're doing at Optiscan. So a little bit about us. We're a small company in Melbourne, Australia. We're only about 25 people, trying to do too much for a small team. But essentially, we've invented this technology and refined this technology over the last 30 odd years. We've built medical devices for other large strategics, including Pentax and Zeiss. We were the first company to build the flexible endomicroscope for Pentax and the first company to build the rigid scope for Carl Zeiss. And they use that for brain surgery. That's FDA cleared, and you can get that in this country. So, of course, the whole narrative is built around immediacy of digital imaging at the subcellular level. So not only can we show you cells, we can show you the cell, the nucleus, and the nucleolus. And then if you're a pathologist, you'll understand the significance of that. So here's a real case of a GI imaging that we did with our collaborators in Germany just recently. imaging the ileum, and this is a human subject. And of course, you're starting to get an understanding of what is the power of this technology. Now, in the context of the company, and so to give you an understanding of where we fit here in vet, we play mostly in the human space. Our collaborators are literally down the road from here. They're known as the Mayo Clinic. Our collaborators here in vet is your college, and we're very proud of having that relationship with you and with the Mayo, because we've set up our presence here in Minnesota as our US office. So that's how we met Caitlin originally, and that's how this collaboration came to be. So we consider ourselves Minnesota-based business, okay? In the US, we're based in Minnesota. So we play in the vet space, we play in the life sciences space, and we play in the human space, both in the pathology and the surgical space. We're trying to build out a series of equipment that is fit for purpose with all of the major players. So if you're a surgeon and you want that capability at point of care in the surgery, we've built a device that will allow you to do that. If you're a pathology lab and you want to use our digital platform as a digital workhorse, instead of you processing all those samples, we've built a device for you as a path lab. And we've obviously then got some additional bits and pieces that we're trying to do. So we've actually built it already. It's a minimal viable product of our telepathology suite, where we can stream those images to you anywhere in the world. So your device will be connected to the cloud, and your pathologist could be in San Francisco, and you're operating here at the college, and they'll see exactly what you're seeing in real time, no delay. So we've had to build that structure and that software ourselves. We're building AI applications for 3 basic applications: breast cancer, GI cancer, and oral cancer. They're the 3 disease entities that we're currently focused on. We're building our own generation of flexible scopes to go into the deep, dark recesses of the bowel. And we're integrating our imaging platform with robotics, and that's part of the work that we're doing with the Mayo Clinic. And ultimately, we believe that not only can we show you cytology and architecture in relation to pathology, we believe that we can work with biomarker companies that are basically looking at specific markers in cells, let's call it a cancer cell, and then look at really precise imaging capability. So that's what we call image-guided molecular surgery. So not only will we show you the architectural features, we'll then be able to pinpoint particular cells, because our imaging platform allows us to do that. So the device that I want to talk to you about, and is built specifically at this stage for veterinary care, is the Inspector, is the second device there. And the feedback that we got was that you wanted something that was light, portable, easy to manage. You wanted something that was at a price range that most vets or vet surgeons or people in the vet space could tolerate. And you didn't need all of the other bits and pieces that we're building for human care. And you see the size difference between our human systems on one side, the surgical platform or the pathology platform, and the small footprint of the Inspector device. That limits, of course, certain capabilities, but we can adapt those other platforms for the vet market as we see the need. Now, all of these platforms have the same basic technology. So we'll make some claims, and hopefully we'll show you the evidence for that. So we have excellent histopathological correlation with our technology. So if you can see it in H&E, we can show it to you in confocal imaging. So our technology is built on confocal laser endomicroscopy. So we have literally miniaturized a confocal laser microscope into that small little footprint. And all of the interesting bits occur at the distal end with that little pen that I'm going to show you. So that front end that you're seeing on the top image is where our whole microscope is sitting, right at the top, okay, in that first couple of centimeters. And there's moving lenses in there, there's fiber optics in there, there's about 150 parts sitting under that stainless steel cover. So we have excellent correlation with H&E. Don't take my word for it. There is about 150 publications that prove that. Now, obviously, when you're talking to pathologists, you want to make sure that they're getting what they're used to. And they're used to seeing images H&E at times 40. So you need to at least meet that. So we've demonstrated through multiple of our own studies, but also with collaborators and independent research, that we can see all of those same features. And it's very important that we show the pathologists that they can see exactly what they're seeing on H&E. So in this case, we've got an invasive breast cancer, and we're imaging various spots of that particular resection. And we're just showing like for like between the CLE and the H&E. Now, obviously, you'll need to learn how to interpret a CLE image, but it's not that difficult. The cells that take up the fluorescent dye will look white, and the cells that don't take that up will look black. So fat, for example, obviously won't take up the fluorescent dye, and you'll see in the bottom image there's a lot of fat in that example, and the top part is, apparently I've got a pointer, so I can point. So that's that bit which is all fat, whereas the tumor is down the bottom here, and you see that it's lighting up with the the fluorescent dye. So the advantage that we have is that our images are digitally native. Okay, so literally the second they come out of the machine, they're already in a digital file, which means you can transmit them, you can put them in a third-party software, you can share them live. You could have, for example, a Teams or a Zoom meeting with your pathologist. You can put them up on the cloud and have your pathologist look at them later. You can come and analyze them differently if you're doing research. And this is the backbone of the telepathology platform running live here. So it's been perfected a little bit more since then. And when I get back, the engineering team will be showing me how fast that is. So that's running live between the States and Australia, sending images back to front nonstop. We're developing, as I said, our own AI, and that's the beauty about these images, that you can also work on them yourselves in your own research. So you don't have to worry about what we're doing. You can do your own. You can, if you're interested in mast cell tumors in dogs, and that's your area of research, you've got digital images that you can manipulate, and you can do a whole heap of research with that. So let me show you. Apparently, we do have music. Let me show you what this looks like in real life. So I'm just painting a bit of a topical dye on the tongue of this dog. I've picked up the probe. I've now put it on the tongue, and you'll watch the screen in the background. That's starting to pick up the images. And you'll see that we're picking up taste buds, the filiform papillae, all of the nuclei. That's all it takes. You put the dye on, you touch the probe onto the tissue. This is now buccal mucosa. So of course, different architecture, different cellular features. That's all the device is doing. The device is just showing you what is there. The device is not analyzing anything for you. Here's an excisional biopsy from an eyelid. I put a drop of the dye on. I put the probe on. This is ex vivo use if you didn't want to use it in vivo. And again, instantly you see the images on the screen. Now you can capture these in continuous format. You can basically do Z stacks, which means that we can image. We don't need to do that again because it's got audio. You can basically see through tissue, which is important. Our technology is the only technology that allows you to image from the surface and into tissue. Okay, so if you're using a topical dye, you'll get down to about 150 micron. If you're using an IV contrast agent, you'll get down to about 400 micron. So it depends on your application where you want to actually end up being. So this is the inspector. This is the typical configuration, but it can come in different configurations, which I'll show you towards the end. It's 1,000 times resolution of what you get on a standard CT and MR. Okay, so the resolution typically is about 1 millimeter on a CT MR, typically, because obviously different machines have different resolutions. Our axial resolution is 0.55 micron. Okay, 0.55 micron, like half a micron. Okay, so that's our axial resolution. So yes, it is 1,000 times the resolution of a CT. Obviously, you'll start with the CT when you're doing your clinical work, and then you'll end up in a path lab. And the pathologist typically is looking at it at about 100, maybe sometimes 200 by the time you put your ocular and your objective. So in our images, you're looking at them at 1,000 times. Okay, so you're seeing on one screen, which is 0.5 millimeter XY, hundreds of cells. Okay, so every screen that I show you is the same configuration. The XY is 475 microns to be precise, but let's just call it 0.5 millimeter. So 0.5 millimeter and your resolution is 0.5 micron. So you can imagine the type of resolution that you're getting. And when we talk about single cell imaging, you are seeing single cell images. So I said you can see the nucleus and you can see the nucleolus. Now this allows you to do a whole myriad of things live. So you're doing dynamic imaging, you're doing imaging where you don't have to cull your animal if you're doing an animal model, for example, you're using a rat or a mouse model. Or you want to come back and investigate something in your dog or your cat, you can do that. Now, we've got a whole heap of images from a whole heap of different systems, so we'll try to go to that as quickly as possible. Very simple system to set up, takes 20 minutes to set up. All you need as a consumable is the contrast agent, which is typically what we like to use is either acridine orange or acroflavin. Acridine orange is commonly found in path labs. Okay, it's super cheap. So your consumables really are zero nearly, okay? And as you saw, I was just painting it on or putting a drop of liquid on it, so it's super easy. If you want to do surgery and you're wanting to image resections or what have you, you need to inject IV fluorescein. That's the safest way. IV fluorescein is FDA approved. So as I said, we've got a whole myriad of publications that support our claims, and most of these, not all of them, most of them are on our website. If you go to our website, you can actually see a selection of those papers. And these are all the areas that our company or collaborators or individual researchers have worked in. So if you can dream about how to use this tech, it's either probably been done or a permutation thereof. So there's a whole myriad of applications, whether it's in oncology, regenerative medicine, molecular imaging, blood flow, cancer, what have you. So I'm going to show you some of those examples. So these are the configurations for our inspector device. We have probes that are meant for surgical use in vivo and some probes meant for ex vivo use. So if you're using it, as I did with that little eyelid outside of the body, so that doesn't need to be sterile, it just needs to be disinfected. And we have probes where you can sterilize, and we're working with Caitlin locally to make sure that the ETO sterilizer here is configured for our probes. Or you can put a sterile disposable single-use sheet on top of our probe and then, of course, do your surgery and then throw it out. So as you can see, the frame rate is 1 to 3.5 frames per second. So you can go really quick in acquiring, get low-grade imaging. You can go really high in your resolution and then collect typically 1 image per second. And that's enough for your eye to keep track of what you're seeing. Any faster than 2, really, your eye can't keep track of it. So it becomes less clinically useful. So I won't bore you with those details. Importantly, you need to understand a little bit about optics and light to use this technology properly. So it's got a built-in blue laser at 488 nanometers. So it will send out a blue light. And of course, because it's a fluorescence technology, it's relying on the amount of signal of light that it's going to capture back, which is why we apply the topical contrast agent. So anything typically that will fluoresce in that blue to green spectrum, which is one of the reasons we like to use fluorescein or acridine orange. So you can capture light at a whole myriad of wavelengths beyond the blue, whether it's in green, in yellow, in red, and you use different filters for that. And we've got built-in filters in the device, and we can customize filters depending on needs of researchers. But we've got long pass and band pass filters to concentrate the light and then obviously give you what you want to see. Okay, so non-destructive imaging, real time, accelerating your research, seamless integration. It just sits on a bench or goes on a trolley. You plug it in and you're imaging within a couple of minutes. So we were down in Arizona 2 days ago, and my colleague met me there, and we were imaging at a partner vet clinic down there. And again, we literally got out of the box within 20 minutes. It was shipped from Australia, 20 minutes. We were basically imaging dogs. And I don't have the images from that episode today, but I'm going to show those tomorrow in my lecture because I didn't have time to process them. So again, another example here. What you're seeing on this device is a tumor. And basically that tumor is invading the muscle structure. And you'll see that's muscle, the very bright bands of muscle And then, of course, the muscle cells around, and the tumor is invading into muscle. So this is real time. This is one of my patients resected in real time, squamous cell carcinoma of the tongue. And then basically I'm looking at the margin later, and the base of that resection still had invasive SCC in the cavity. So we went back and actually did a little bit more resection. Okay, so apparently this is all about helping you think about research ideas. So let's go through. So these are 3 sequences. They're all on video. The first one is from the Burrow Institute. So that's a glioblastoma island, tumor cells in the middle, and you can see blood flow going around that. This is blood flow in real time. So you're seeing erythrocytes flowing through the blood vessels. Now, our images for the inspector are TIFF format, and then the images can be exported out into any image analysis software. So all we had to do with this is export the images into ImageJ, and then you've got an AVI, which is what basically you're seeing now as a video. In the middle, you've got a sequence of blood flow through a mouse pancreas labeled with IV fluorescein. And on the far end, you've basically got a set of images looking at calcium level changes in the mouse intestine. And that's obviously over time, and that's put together as a sequence. And you can see those light up with a particular probe. So FITSI, for those who are involved in research, FITSI is the best, easiest fluorescent agent that you can use for this sort of research, or anything that you can bind to FITSI. Of course, there are some below FITSI and some above FITSI, but FITSI is the equivalent of what we use with fluorescein in live animals. This is a paper out of China where they were looking at nanocarriers loaded with a drug, and they're looking at the uptake of the drug across time. So it's a couple of hours. And you can see from when they start in A to when the nanoparticles are delivering the drug, this is all done live. Typically, they would actually have to cull their animals and do sequential animal studies, whereas here they're just imaging the same animal over time, and they got this whole sequence with our probe all in one hit. So that's the beauty about using these for longitudinal studies. So my job now is to give you ideas about how to use our tech in your research. And I think I'm doing reasonably well for time. So I think we might be able to go through some of the cases. So on this example, we've got a melanoma model in a nude mouse. This particular group was looking at tumor angiogenesis. You've got normal dermal microvasculature on one side, and then you've got the melanoma-affected vasculature on the other side. You can see clearly that it's disrupted. Now, obviously, like anything, if you know what you're looking for, you know what you're looking for. So if you don't know what you're looking for, if I showed you that image on your right, you'd say, all I see is squiggly white lines. Right. So if I said to you, yes, well, that's the vasculature. Oh, yes, now I know what I'm looking at. Now, that's the same thing that you do in your research every day. You don't analyze your material just because you've seen it once. If I showed you an H&E of this, you still wouldn't know what you're looking at until you learn how to do that, which is whether you're a pathologist, a radiologist, a surgeon, a vet, you need to learn how to interpret images, whether we're looking at an X-ray, a CT, an MR, a H&E, or now confocal, laser endomicroscopy. So CLE images will look very similar to those images that you're going to see on H&E. Now, that also depends on the model that you're using, depends on the dye that you're using, depends on what you're trying to image, and the magnification, because we can actually increase the magnification and give you optical magnification on top of the 1,000 times mag that you get off the machine. So some of the images you'll see look closer to you and some look further away, okay? So this is an example of something that we've done more recently with the Stanford group. They were looking at an osteoarthritis model, and they wanted to see whether our tech would be able to recapitulate the standard H&E model that they use every day for their human knee osteoarthritis model. So There is a standard grading, 1, 2, 3, 4, what have you, in osteoarthritis, where they see chondrocytes, they see the damage that is caused down to bone, and they've got a diagram to actually explain to them what the model looks like, and then a set of H&E images. Now, obviously, this has to occur after a path lab is processing the knee. The images up the top, which shows basically the chondrocytes, the hypercellular chondrocytes with a red arrow, they're grouped together in clumping. That's exactly what they see on their H&E images. Now, those images were all done on the spot. The second the knee came out of the patient, they were imaging it with our device. So they did not then need to actually go about processing and waiting days later until they understood what was going on with that patient. Now, obviously, for the purposes of this demonstration, we got the H&E because we wanted to show them that they looked exactly the same. Okay, so this is a recent example. This is another recent example. Cornell were using this to look at equine ileum. So they were interested in I'll probably get this wrong, is it tension or torsion? That's right. So apparently horses have this significant problem. So I'm learning things every day. Horses have this significant problem, and apparently there's a model for this, and it's published, and they were trying to recapitulate this model where, of course, there's damage to the vasculature, then it results in necrosis and what have you. So, of course, the first step is, well, could we actually image the horse ileum? And so this is just using topical acroflavin. So obviously they've done an enterotomy. We just paint the topical acroflavin on it, put the probe on, and that's what you see. And that's their histology, not ours. So that's our CL image and their histology. So we had to look through all of their histology. So I get to now look at vet pathology too, on top of my human pathology. So I'm learning along the way. So these are more recent images. Now, this is where I thought if I run out of time, I can sort of stop here and say, oh, you've got endless opportunities. And you just clap, I'd go home, and that's it. Now, this is where I get into more of the detail. I've already shown you this one. Okay, I want to show you more examples to give you more ideas of what you can actually do with this. And then I want to take a pause and start to ask you questions about what you're doing and what you want to do. So intraoperative results of gliomas and adenomas and other CNS pathology from Mark Proul, who's our collaborator down in Arizona. And we were down there meeting with him on Tuesday. I think that's yesterday. I've lost track of time. And we still work with his team looking at our current generation to create more and more evidence around fluorophores in particular that we want to basically use in research. So a whole myriad of imaging of particular structures and tumors with both CLE and with the recapitulation with H&E. So you'll see that the structures are like for like. Blood vessel imaging in the CNS, again from Mark. More recently, there's been a big push in looking at squamous cell carcinoma in animal models, whether it's for NQO or other carcinogens. In this particular example, this group were looking at this marker called PARP-IFL, which is a fluorescent marker, and PARP-I basically comes up in cancer cells. So it starts to accumulate when the cell goes from normal to dysplasia to cancer. So of course, as it's becoming cancerous, the PARP-IFL is lighting up. And guess what? It's a fluorescent tag, and our product is basically designed to collect fluorescent images. So you're seeing basically the PARP-IFL light up in this cancer model that they've developed, going from hyperplasia to dysplasia to SCC. Just happens to be that's an area of particular interest to me. Other examples, imaging the equine endometrium. I can't tell you that I know anything about equine endometrium, but I know that we're seeing the same structures, just to again give you an idea of what's been imaged over time and what is possible. So the idea here is that you can image small animals, anything from a mouse up to a horse. That's a lot of flexibility, and which is why we provide those options around the probe configurations. We can make the probe longer, we can make it shorter, we can put a sheath on it, we can take the sheath off. So it gives you a whole heap of flexibility, and we believe there's a whole myriad of applications in vet research for you to use this tech. Arthroscopy examples, there's several of these examples with crush testing and what have you. So whether you're looking at tendons, whether you're looking later on, you'll see collagen, you'll see cartilage. Again, you're limited only by your imagination. So here's a sheep cartilage defect model looking at the condyle, and again, stained with acroflavin in this particular instance. Again, looking at that example that we just showed you from Cornell, and again, looking at knee cartilage, this was a past example. And every group that we go and demonstrate this to, they say to us, can you show us some studies that demonstrate the utility in my area? So we have to point them to these papers. And as I said, the papers and the links are on our website, but everyone wants to do it for themselves. It's like no one trusts the other researcher who did that. So we showed them this paper and said, look, you can image chondrocytes. Yeah, but we want to see if we can image chondrocytes. It's like, okay, that's fine. Go ahead. So of course, we converted the Stanford guys and the Cornell guys in this particular instance. So there's a whole myriad of applications. In this instance, this is autofluorescence, and the device will pick up autofluorescence. So if your tissue is very fluorescent naturally, which is where autofluorescence comes from, you'll actually be able to pick up the signal without putting a dye on it. Now, we put the dye on because we're looking at normal structures, so we can enhance the light coming back into our filter and our fiber. So before damage, straight collagen, they're the straight collagen fibers on the left, and then the disorganized collagen fibers, and guess what they do? They start to fluoresce, and you're picking up the cellular structure just because you're picking up the fluorescent pattern from autofluorescence. So if your tissue or your area of interest has autofluorescence, you can pick that up. Of course, you can enhance that with a dye of some sort. What are we looking at here? Imaging of the eye, and we're going to show you some other cool eye images, especially towards the end, so you can see nerve structure, epithelial cells. We did image a dog eye on, well, yesterday. Again, I have similar images, but I haven't processed them, so they're literally fresh. What are we imaging here? Sheep cervix. Now, in this particular instance, this is only a nuclear dye. So what you're seeing on the right-hand side is only the nucleus light up. Now, when you pick the fluorescent dye, you need to know what parts of the cell is going to take up that dye. Now, some of them are very intense and they'll be taken up in the nucleus, and typically with those ones are bound to DNA, but many others, they'll actually bind on the cell surface, some even in the cytoplasm. So now you can use that selection of your dye and your fluorescent marker to then determine what you're going to see later. So if you were looking at this image on the right and say, I can't see cytoplasm, that's because it's not staining the cytoplasm. Again, you design your studies the way that you need to. The tool is just a digital microscope, okay? In this instance, we're imaging squamous epithelium from normal all the way to severe carcinoma. Again, in this particular instance, it's just topical. And this is the sort of pattern we see in squamous cell carcinoma also of the oral cavity and head and neck. Actually, no, I'll go back to that one. Probably importantly, just by looking at that as an example where you're going from normal through to dysplasia through to carcinoma, you're picking up the same features that you would if you're a reporting pathologist, which means you don't need to come up with a classification system. We use WHO diagnostic features for all of our images. So if you're a pathologist or you're working with a pathology colleague to do your research, they don't need to learn anything new. So if it's a breast tumor, we're using the WHO breast classification. If you're using a head and neck tumor, it's the WHO classification. So we don't want to teach you anything new. Okay, so bronchoscopy examples. This is a good reminder to tell me that the imaging that you see with our device is on-face imaging. The images that you see when a pathologist processes a formalin-fixed paraffin-embedded section is cross-sectional. So you need to recalibrate your brain to think, okay, I'm imaging this way through the tissue and it's on face, which is why we give you that capability of stitching all the images and creating a Z stack. So you can literally image from the surface all the way down to wherever you want to finish. And as I said, that's 150 to 400, depending on where you are. Okay, looking at microvasculature and cell tracking, so with specific markers, and you can see here they've got the FITC dextran and FITC labeled blood cells, red blood cells, so they're tracking basically the signal as it's moving through the vasculature. And just another example of that, so I'm not going to bore you with that. This one I love. This one I love. See the image on the right, bacteria in the mucus of the mouse ileum stained with 0.05% acroflavin. That's Helicobacter pylori. Okay, so this one here, if I can point to it, you see these little white strands bunched up, little bacteria. So you've got ileum and the epithelial structure, and then you're basically seeing Helicobacter in real time. So now people are starting to use this tech to do food intolerance assessments. Obviously, when they're looking for Helicobacter, there are other tests to do, of course, assessments of Helicobacter. But when they're doing GI endoscopies, colonoscopies, they can actually see this in real time, okay, which is quite neat. And that's taking off in the GI space. This also shows me and reminds me that you can pin or place your animal in any which way dependent on your model of disease. So obviously people ask us, how do I image? Well, as long as the probe touches the tissue, you can image. Now, how you get the probe to the tissue, that's none of my business, okay? But everyone's got their own way. Some people are doing, you know, intracranial imaging, and they do a little hole through the calvarium and pop the probe onto the brain. Well, it's different if you're doing, for example, ileum imaging in a little mouse. And of course, it's different if you're doing that in a live patient dog, for example. So how you apply the probe is up to you as a clinician or as a researcher. We're only providing the technology. So this is what I was alluding to a little bit earlier. So our colleagues in Germany, and we're still working with Professor Kieslich, who's published this paper. They're testing our current next version of flexible device. They found that when they were doing their assessments in GI imaging, that they could actually pick up cells that were literally exploding in front of their eyes. And it turns out that these cells that were exploding were basically exploding as a consequence of intolerance to certain allergens and foods, which is now they've modeled this process, and they use this as a clinical test to assess people for intolerances. They've got a video of this, which is more impressive than just looking at a still image, but you look at it live and you see the image, and then the cell literally explodes like a volcano. So lung imaging, these are triple labeled with different markers. Liver imaging with apoptosis. This is where I start to go through the presentation really quickly. Liver imaging again, looking at different functions, same paper. Mouse liver. Micrometastases in a mouse model of liver disease. Kidney. I've showed you this one earlier. Not going to repeat that. Tracing of transplanted intestinal epithelial cells. So again, if you're doing anything in the regenerative space or the transplant space, you can use this to track cells. If you've got the right marker, our probe will find it. I've shown you this one. Other examples, intramucosal bacteria and inflammatory bowel disease. Looking again at the particular clinical, histopathological, and the CLE features in adenomas and hypoplastic polyps, and how you use them to differentiate. And they're diagnosing these features on the spot now without having to cut them out and send them off to the lab. Pancreatic cancer in a rat model. I'm not sure what you are doing as far as your research, but I'm just trying to give you all the possibilities. In vivo rectal mucosa barrier function. I mean, everyone's thought about these weird and wonderful things to do. And in this instance, it was HIV prevention studies, localization of different markers. So this is YFP. You can localize GFP if you're using YFP or GFP in your studies. And then, of course, you can change those filters, as I explained earlier. Rat pancreas. This is tissue sectioning. So I wanted to show you this one because this is a still image on the left-hand side. And the video that's playing on the right-hand side is the Z stack in that same spot. So you're basically imaging from the surface down to 100 odd micron. And that's typically at 5 micron intervals. You can change that. You can do it at 1 micron interval if you want, or 2 micron interval if you want. And then again, you just create that Z stack. Now, also, when you take a standard CLE image, you can see they're all grayscale. You can colorize them later in ImageJ or any other software. So this one has been colorized after the fact. And you can see that it's using Alexa Floor 488, which is the sweet spot for FITSI imaging with our probe. Other examples of thoracic malignancies, imaging heart muscle, imaging protein. Okay, so again in cardiac muscle, so this is YFP expressing transgenic. What are we imaging here? Also muscle. Muscle is easy. Blood vessels and tight junctions and blood flow through vessels. And of course, you can mark those cells with your particular marker. I've shown you this one before. I'm not going to bore you with the detail. This is from the same study looking at mucosal barrier function. This is now becoming a significant human clinical diagnostic tool with what they call leaky gut. So again, go back to that same group in Germany, looking at the explosion of those cells and the intolerances and how they're using that now to make diagnoses around IBD. Again, just a reconstruction of zebrafish blood vessel endothelium. This one's expressing GFP, so green. The other one was expressing yellow, but you can see that it picks up different wavelengths. And this is, I know, my last one because I left this one to the end. This is zebrafish eye stained with acroflavin. You'll see the image on the right is the still image. It's post-colored based on the features. And this one on the left is the Z stack. So again, you're stacking through the full thickness of the eye to get a full range from surface all the way down to the structure that you're trying to image in real time. Right, so 45 minutes. So this, as I said, is just really aimed at giving you an idea of what is possible with the technology, what people have done. There's a whole heap more. Obviously, I haven't had time to go through that, but I'm just trying to give you some sort of idea. Please, happy to take any questions around how the tech works, what the relationship with the college is, anything specific to your research, if I can answer it. If I can't, then we'll give you answers later through our technical team. And really, we're trying to invite you to come and submit your research ideas to the college through Caitlin. We'll have a device here soonish. We've already started to write grants for certain projects. We obviously have a priority list and we're going to work through them. I don't want to speak out of place in relation to costs and this and that and the next thing, but the relationship between us and the college is we're providing the technology free of charge. Okay, I may have misstepped there, but what they charge you internally and how that operates, whatever, has got nothing to do with me. Our job is to facilitate the research that's going to occur here in the college. And as I said earlier, we're very proud to actually have the relationship here with the college. And you're our only vet collaborators from a tertiary institution point of view. So as I said, we want to support your research. So please ask us questions. Thank you very much for your time, and over to you.
Thank you, Camille, for a great presentation. Thanks for coming back. Welcome to Minnesota once again.
Nice to see you again.
My name is Alonso Guedes, Associate Dean for Research and anesthesiologist. It piqued my attention when you were talking about the if I have a tissue that's fluorescent, that this has the capability to pick up natural tissue fluorescence as well. And so I was wondering about if you have the ability to do different wavelengths for simulation. It seems like you have a 4088, right, is the current one. That's one question. And the other one is the acquisition speed. To think about like resolution, if you have like very fast dynamic processes going on, what's the acquisition speed? Thank you.
Okay, so the frame rate is 1 to 3.5 frames per second. If the frame rate for the image is 1 to 3.5 frames per second, and that's if you're operating at 1024 by 1024 resolution, you'll only get 1 image per second. If you drop that and you go to 1024 by 256, you'll get up to 3.5. So if you've got a dynamic process and it's quick, you should be imaging at the fastest speed. However, you will let go of some of the resolution of the quality of the image, right? So there's a trade-off there. If you want the crispest image and the process is not very quick, then you should be imaging at 1024 by 1024. Now, typically, we like to image at 1024 by 512 because it's a balance between the resolution. Sometimes the resolution is too much and because it affects the speed, right? So the sweet spot, I think, is 1024 by 512. And I image with that all the time. Then the other question is about the laser and the different channels. And okay, so the tech is built on 488 laser for a reason, because you actually get a wide spectrum after the excitation. We have played with red lasers, yellow lasers, green lasers. The imaging quality, therefore the resolution, is not as good. So you forego a lot of detail if you're not operating in the blue spectrum with the way that our probe is configured, okay? So currently we would suggest to you, and the configuration that we're providing to the college is only the blue laser, and that's intentional because you're gonna get better imaging. And remembering that we want these devices to be clinically useful, and clinically useful means the clinician and the pathologist need to be able to see things that at the same resolution that they're used to. So we could provide it in green or red. For research, it's okay, but for clinical practice, it's not. So we're still sticking with the blue at this stage. Yeah. You can do, gets a bit more technical. You can you can use the same laser, 488, collect your images at different wavelengths later with the banding and the filters, because some of the filters are custom. We can build the filter just for your needs. And then there's a whole algorithm, which I don't know how to do, our technical guys know how to do, where they can actually assist you to create the spectra as if you were using a red, yellow, or whatever laser. I don't know how to do that, but our technical guys know how to do that. Yeah. Way beyond my pay scale. Other questions?
Yeah, has anybody ever used your technology in something like a fret probe type configuration where you're using like multiple fluorophores at the same time?
There have been studies, yes, with multiple fluorophores. So one of those, I think, was lung from memory that was triple stained with different fluorophores. So the simple answer to that is yes. And the technical guys know how to actually take the signal out from each of those fluorophores and then merge them. There's a funny word for it from research. But yes, you can strip it and merge it back together. So yes, the answer simply is yes. I don't know how to do that. I can barely load images into ImageJ and create an AVI. I recently learned how to do that.
All right,
I'm just a simple clinician. That's at the back.
Okay, so there are some questions on Zoom. So Dr. Lulich asked, what is the cross-sectional measurement of the probe, and will it fit through the biopsy ports of most endoscopes?
Ooh, okay, very good question. So the smallest size probe that we're providing is 44 millimeters long, so 4 centimeters long, 3.5 millimeters wide, 3.5 millimeters wide. That's a rigid scope. Our scope currently is not designed to go down a working channel of a standard endoscopy scope. Okay, so the simple answer there is do not try to put our probe down an endoscope. However, we are building a narrower, smaller, thinner, shorter probe that will go down every single flexible endoscope. You're going to have to wait a couple of years to get your hands on that one.
Okay.
So that will be 2 centimeters long, and it will be 2.8 millimeters wide, and it will go down every single working channel.
Perfect. And then there's another question that says, there's a comment also that says, interesting data and thanks. I'm a dermatologist faculty at the CVM, and as I heard you talking, I was dreaming with multiple potential applications in the vet derm world beyond neoplasia. So there's 2 questions. So the first question is, are there any basic research showing what the imaging findings would be in normal skin for humans, dogs, or cats? And then the second part of the question is, are there any potential applications for diseases such as masses or neoplasms in the ears, which are usually not easily accessed for biopsies without video otoscope and general anesthesia?
Okay, I've heard the first one before, not heard the second one. There are studies looking at normal skin structure. I know a lot of them in human. I don't know if that's been done in cats and dogs. We can find out for you. Keratin is an impediment to fluorescence CLE because the keratin layer is so thick. Basically, it's basically taking the light away from the area that you're trying to image. Having said that, CLE has been used extensively in derm. The ear one, I don't know if anyone's done ear imaging or diseases. That's a new one to me. No one's asked me that before, but the probe, as I said, is only 4 centimeters and 3.5 millimeters wide. So if you think from a clinical point of view, you can get it into the right place of an ear, which I don't know in your animal, then the answer simply is yes, you can image it. Maybe you need a bit more flexibility, so you might need to wait for the flexible probe. I don't know, but I would say once the unit is here, try it.
All right, that's all the questions from Zoom. Does anyone else here have questions?
So Anna, what you presented is imaging of tissue. Could this also be applied to imaging of organoids?
Yes, I didn't show that, but we've got a lot of data on that. So if you're interested in tissue culture, cell culture, organoids, there are multiple papers now using, published using that, but also many more research groups, because they're growing organoids, they're using our tech. So we have a life sciences product called View in Vivo, which our inspector device was based off. That is being used to image cell cultures, organoids, what have you. The beauty of that is you can take the same probe, which is what we call our ex vivo biopsy probe. You can take that same probe and you basically can use it in the hood. So our device, if you want, comes on a trolley, and then you basically just bring it to wherever you're growing your cells. And we've got multiple examples of that. I just didn't show any of that because, one, I didn't know what the research groups were doing here, but that's been done extensively and you get very, very good imaging. That's actually very easy to do that. Yeah.
All right, thank you. I think we're right at the end of time. So
Thank you very
thank you again. And if you have, like Dr. Farah said, if you have any questions, just email me or come stop by CIC. I'm happy to chat further. So